So what has the surgeon learnt? And I think for all health professionals, and I think certainly for surgeons, we keep learning so much from our patients, their families, and their supporters. And I think cochlear implants for the older age group are really, as I said to Sue previously, is a really important area where there's so much need and increasing demand. May I have the next slide, please? So I just want to look at a bit of background, and I think all the talks today will really mesh together as a beautiful network of ideas. And two common questions I get asked are, am I too old for a cochlear implant? And also, should I wait a bit more for my hearing to drop further? And I just want to share with you some of our data on those two questions. And then, as Roxana has said, hearing is not an isolated issue. It's very much part of our whole being, and there's many different aspects, but cognitive decline is something that's been really uh, increasingly known about in the more recent years. So our indications for cochlear implants keep changing, and basically cochlear implants are indicated when hearing aids are not enough, and that's why people need to see cochlear implant programs to be formally assessed. And there's some good, easy screening tools for people to know whether they should actually then go and see a program and be assessed. Next slides, please. There's a lot of great guidelines for out there regarding indications for cochlear implants, and also these resources for sort of long-term care and optimization. So we've got the living guidelines, which Leo's been very much involved. And I think CIICA has so many fabulous resources, just like these talks, to give us guidelines and ideas about best long-term care and when people should think about a cochlear implant. Um, can I go to the next slide, please? So often we suggest to people, with your hearing aids on, just ask these three questions. Do you find it difficult to hear on the phone? Are you no longer able to hear children's voices clearly? Or do you struggle to hear in a crowded place? And if you answer yes to any one of these questions, then it's something to consider whether you should actually think about a cochlear implant or be assessed formally to see whether you'd benefit more from a cochlear implant than from hearing aids. And a lot of people don't realize that they actually would do better with a cochlear implant. Can we move on to the next slide? So, as Roxana mentioned, we have an aging population, and for us in Australia, we can see from this graph on the left-hand side from the Australian Institute of Health and Welfare that our proportion of population 65 and above is going to double over the next 40 years. So at present, we have about 10% of our population in that 65 and above, and in 40 years, we'll have well over 20% of the population. And you can see in the middle of the screen this graph from the UK, just showing that dementia is linked with, well, increases with age. And so with an increasing aging population, this is going to be a larger factor. And just if you press the slide again, a few more pictures will come up on that slide. Yep, and again. So we know 1 in 3 adults have hearing loss over 65. But as we get older, it's all about good quality of life. And you can see from our Australian life tables that at age 65, the average person has another 20 or 22 years of living. Um, at 75, you've got a life expectancy on average of 12 to 14 years, and at 85, another 6 or 7 years. So it's all about having good quality of life as we enter our sort of third act in life. And having a cochlear implant and hearing well is really about that. So let's look at what we know are these questions. Am I too old for a cochlear implant? And should I wait for my hearing to drop further? And these are common questions I get asked when I'm consulting. So we looked at a study and published a number of years ago, 785 patients, and we looked just at their sentence scores. So for us, we normally do these CUNY sentence scores, but each country will have their own sentence scores and word scores. Now, everybody sort of says, well, look, but it's really in background noises when I have trouble. But often when people come, they can't actually do a sentence score in noise because their hearing is so poor. So just explaining why we're looking at these two scores. Now, in the top, you can see the preoperative. So these are a normative, these are box plots. And so everybody's included in that plot. And where that middle line is in that blue or red box is sort of the median person. So preoperatively, people, we had our sentence results and our word scores. And then you can see as you look down the graph, at 3 months, you can see the box plot. Yep, thank you for pointing. Has markedly improved. So the outcomes for CUNY sentences have increased, and certainly also for the word scores. And then 6 months and 12 months. And if you just press another button, go forward. Leo, yep. And so what we found with our patients, in the blue, we have people under 65, and in the red, we have people over 65. And in fact, everybody improved, well, people improved over time after their cochlear implant, but there was no significant difference in the outcomes of those under 65 or over 65 for sentence scores or for word scores. So, you're certainly not too old to benefit from a cochlear implant, and that's very reassuring that people have the same, impressive outcomes as you can see from this. And certainly 12 months isn't the end of your improving your hearing ability with a cochlear implant. People continue to improve after that. If we then looked at if you had severe hearing loss preoperatively versus profound hearing loss preoperatively. So just was your hearing a little bit better or a little bit worse in the preoperative group? What we found was that those with severe hearing loss, so now the severe group are in the sort of blue and the profound group are in the red, we found a significant difference for those at 6 months and 12 months. And so for those people, if you had a cochlear implant when you had severe hearing loss, you actually did better than if you waited until your hearing dropped to profound. Now, you can still see from the graphs that you certainly improve, and there's a broad range in outcomes. But with that large cohort of over 700 patients, we could show statistically you're better off stepping in when you haven't lost too much hearing. So the take-home message is don't wait for further hearing loss. Step in when you're having trouble, and think about a cochlear implant. Now, the next slide, please. So, and just press again. So with adults, and we often hear this, that people say, look, I wish I'd had my cochlear implant 10 years ago. This is from an old study, but people often have been a good cochlear implant candidate for over 12 years before they actually present to a cochlear implant program. So it's worth being assessed, and sometimes I say it's a bit like you're putting your toe in the water, feeling the temperature, and then you have a bit of a think, and then you put your toe in again, and it's about gathering information and becoming more comfortable with the idea of a cochlear implant. But we really encourage people to be assessed when they're struggling with their hearing aids. So just to finish off, let's look at, it's not just about hearing. So if we can just press on with the next slide. And as Roxana sort of mentioned, there's a lot of work looking at hearing loss as a modifiable risk factor for dementia. And the Lancet have done large sort of publications in 2017, 20, and 24, looking at these possible risk factors for dementia and identifying that hearing loss is probably one of the largest risk factors in middle age that maybe if we can treat better and manage better, we can actually then potentially reduce later dementia. Next slide, thanks. And Frank Lynn, who is a total superstar, did a study which is often quoted, and I think the slide is the graph is speaks for itself. But they followed up 639 patients who were dementia-free. They looked at their pure tone audiogram on average and divided them up into mild hearing loss, moderate, and severe hearing loss, or more than, more than 70 decibel level. And they followed people up, and they found that the risk for developing dementia over the following up to sort of 10 years actually was related to, or could be related to, their hearing loss. So if you had mild hearing loss, you had 2 times the risk, moderate 3 times, and if you had severe hearing loss or severe and profound, you had then 5 times the risk. So it's important that we look at optimizing our hearing, because it makes a big difference to, as Roxana was saying, our socialization and our whole sort of integration. And here we are seeing our cognitive function. Next slide, thanks. And then Professor Franklin and colleagues then progressed to do this huge undertaking of the study. Just press one more time. It's called the Achieve study, and they enrolled 977 people in a randomized controlled trial with a 3-year follow-up. And they either had people who joined them from, internet advertising, but they also had people who were already in a study called the atherosclerosis risk and community study. And people were then divided up into either having a hearing intervention, which was a hearing aid, because remember, in America, you don't necessarily get a free hearing aid through your health system, or they had patient education on a regular basis. And then they looked at their outcomes on a whole battery of tests over at 3 years afterwards. Just press the forward again. And in a short period of time, so 3 years is not, a huge length of time for follow-up when we think of our cognitive function. But in that short period of time, they found that those with another risk factor, which was the atherosclerosis risk in community group, had a significant benefit from actually having hearing aids rather than the general health education. So this is certainly encouraging evidence that hearing aids are helpful. Again, it didn't show it for everybody, but you think about dementia or cognitive decline as a very multifactored health problem. And so I think the results here in a 3-year follow-up are very impressive. Can we go to the next slide? And just for your interest, there's a number of theories why hearing loss and cognitive impairment can be related. So it might be that there's just increased cognitive load trying to understand what is being said. And so the brain can't actually do some of its housekeeping function and put the rubbish out or whatever. So you're just working harder. And so it means that other activities that are going on in the brain get sort of put to the side. Hearing loss can actually change the structure of your brain, and that might be a factor leading to cognitive impairment. Also, hearing loss, often you change your world to be a little bit more smaller. Maybe you're not putting yourself into more challenging social situations, and that can then lead to cognitive impairment. And then, of course, there's common etiologies such as microvascular disease and aging and other things. So we don't really know exactly why, but there's a number of theories why these two issues can be linked. Next slide, thanks. I just wanted to flag, Franklin was really pushing that everybody can actually do a simple hearing screening test, such as the Mimi app, which is for free, and you can get a fairly accurate screening sort of test and know what your hearing score number is, and so follow that over time. So step into hearing support, such as hearables or hearing aids, or then a cochlear implant as needed. And next slide, thanks. So in conclusion, and just press down on that if you can, Leo. Older people do just as well with cochlear implants. Please don't wait for your hearing to drop further. And there is sort of screening for cognitive impairment, anxiety, and depression. We should be looking at considering those as part of sort of the holistic care for patients. Thank you very much.